10-month-old boy presented with history of respiratory distress at birth, and it diagnosed as a transient tachypnea of newborn at birth, and to some extent recovered, sent home. But wet cough since age of 1 month is persisting with nasal discharge and ear problem. One episode of hemoptysis in recent past, and there is a consanguinity but no sibling death. Examination showed a clubbing 2 plus with a mild pulmonary arterial hypertension clinically, and received multiple courses of antibiotic, 3 courses of anti-TB drug. So any child with cough and some abnormal features on X-ray in our country, people treat them with anti-TB drug. But if patient is not responding as expected, think of various other conditions rather than giving a repeated courses of anti-TB drugs and so on, or changing to the one after the other antimicrobials. Next slide. So analysis of clinical features suggests that 10-year-old with a transient tachypnea at birth and wet cough since age of 1 month, nasal discharge and ear problem, episodes of hemoptysis, consanguinity, clubbing, and mild pulmonary arterial hypertension. He received 3 courses of anti-TB drug, and all symptoms and courses suggest that chronic respiratory problem, possibly bronchiectasis, is there. As you can see, wet cough, along with that, there is a clubbing and respiratory difficulty as indicated by pH. Next. So you have to look for the underlying cause. What may be the cause of this underlying cause of bronchiectasis? And there are multiple studies, and depending on where you are working, you may think of various underlying cause. And as you can see, this is a study carried out at AIIMS, and most commonly it was post-infectious bronchiolitis, bronchiectasis. It is very difficult to, because as you can see, even in our case, 3 courses of anti-TB drugs were given without any objective evidence. So it is very difficult to say whether it was because of a post TB or it was because of some other problem. Primary ciliary dyskinesia was in 15%, allergic bronchopulmonary aspergillosis in 7.5%, immune deficiency in 6.2%, aspiration syndromes in 3%, and others were 4. And we could not identify the cause in 36. It depends that what all infrastructure for carrying out the investigation for a child with chronic suppurative lung disease you have, and it will improve your diagnostic yield. This 36% may become 10% or 15% if you are more diagnostic profile like immune deficiency, PCD, CF, and all. In this series, we did not include cystic fibrosis because it might have caused the bias, because our center is known for a CF care. Next. So the investigation for a suspected bronchiectasis is, you can do X-ray, which will give some clues regarding the suspicion of bronchiectasis, chest CT or specifically HRCT, and bronchography. As you can see, the bold is chest CT, which is HRCT film, and that has replaced the bronchography. Earlier used to be the gold standard. And confirmation of underlying cause, you can do a bronchoscopy to identify foreign body, bronchial stenosis, malformation, immunoglobulin profile, HIV testing, or other immune deficiency. Workup for TB is important in our country because it may be that there is a relapse of tuberculosis or reactivation of tuberculosis. Sweat chloride and mutation for CF, X-ray PNS for supportive evidence for associated problem of primary ciliary dyskinesia. You can do some screening test like a nasal NO, high-speed video microscopy, and nasal brush for EM, and mutations for diagnosis of primary ciliary dyskinesia. For monitoring, you can do whenever it is required X-ray and chest CT, not required to be done every year. Bronchoscopy as and when required. Lung function test you can do every 3 to 6 months, which suggests for all chronic respiratory diseases. This is one of the objective parameter to give us an idea whether the patient is responding static or worsening. And sputum culture for deciding about what antimicrobial to be given. It should be done every visit, so that whenever a child comes with a breakthrough visit with an acute exacerbation, you can decide about antimicrobials. Next slide. So in this patient, You can see this X-ray shows a hyperinflation, and you can see this is it may be passed as a normal, or there may be few infiltrate, but if you see carefully, retrocardiac shadow, a triangular shadow, suggests that it is probably a collapse of the left lower lobe, and which is confirmed by CT scan. You can see in the CT lower down that there is a collapse of the left lower lobe with a dissection, and even there are some signet ring appearance in the central part in the bilateral lung field, which suggests signet ring is one is that you are seeing a ring like shadow, which is because of the dilated bronchus, and at the nearby there is a vessel which is small, and once the airway is bigger than the vessel, which suggests that possibly there is a bronchiectasis. So this is the gold standard for making a diagnosis of bronchiectasis if your airways are dilated. And then next slide. Then because the child had a hemoptysis, so we did a previous slide. We did a previous one. We did a CT angiography for the thorax, and you can see this. Generally, you will not be able to see this. The arrow is showing a dilated or prominent bronchial artery. So this was going in the inflamed portion of the lung, and that was responsible for bleeding. So in such a situation, if there is a mastohemoptysis, you can get it embolized. Next. Nasal NO for this patient is 30 ppb, and this is low, and low may be in the primary ciliary dyskinesia, and it is considered to be one of the good screening tests. We did a nasal brush for high speed video microscopy and EM, and you can see here that the EM is showing a distorted cilia, and so diagnosis of PCD was made. Next slide. This is a slide of HSVM. Dr. Smriti, you can just click on both these videos. The first video, you can see there are few these cilia, but they are not moving. Next, click on the next one, and here you can see these are the cilia on the epithelial cells, and they are moving. So this is a immotile cilia, and here they are moving, and depending on what type of movement it is there, you can say that whether it is a ciliary dyskinesia. Next. So final diagnosis was primary ciliary dyskinesia as indicated by clinical phenotype with a an important thing, clinical phenotype was TTNB at birth and persistent wet cough. This suggests very highly that we are dealing with primary ciliary dyskinesia. Then the child had a low nasal NO, and then there is a immotile cilia. With hemoptysis was because of the collaterals, and treatment was, again, as of now we do not have a definitive treatment, but you can give antibiotic for whenever there is exacerbation, supportive care, embolization, and regular follow up. That is the major mainstay of the treatment. Next slide. So regular follow up in which you should be doing anthropometry for any respiratory or any chronic disease, clinical findings, spirometry, sputum culture, nutritional advice, increase intake, chest physiotherapy, that should be emphasized. That is a very important thing, whether it is a CF, other cause of bronchiectasis, or primary ciliary dyskinesia, and explain about the nebulized medication, early recognition of the exacerbation by increased cough, sputum, change in color of expectoration, hypoxia, and change in chest auscultation, early institution of antibiotic by seeing the last culture, as I emphasize that we should be doing a surveillance culture, and to continue specific therapy if at all it is there. Next. Medical treatment in majority, and red flags are if a child is not growing well, hypoxia, PAH, recurrent exacerbation, diagnosis is unclear, hemoptysis. Next slide. Sent to the referral center for expert opinion. Okay, if any of these are there. So we may go to the next case in 5-7 minutes. Next slide. So the last case is persistent tachypnea, low grade fever, X-ray showing patches, and high leukocyte count. Next slide. So this 8-month-old boy from Allahabad presented with acute onset cough, fever, and respiratory distress 2 months ago. So 2 months he is continuing to have this problem, and he was fed dal forcefully, hospitalized and treated with oxygen, IV medication, multiple antibiotics, nebulization. Next. So fever got relieved after 5 days, but cough and respiratory distress persisted. In view of persistent symptoms, started on anti-TB drugs. Next. So he has a tachycardia with a heart rate of 150, respiratory rate of 64, oxygen saturation 90 to 95, and breath sounds were decreased on the right side and crept right more than the left. His total counts were high, 34,000 with 70% polymorphs, and you can see there is a dense parahilar consolidation right more in the left. Next. So analysis of clinical features are acute onset cough, respiratory difficulty with dense consolidation on X-ray, high polymorphonuclear leukocytosis with some improvement, but tachypnea persists and very bad X-ray. And there is a dense consolidation specifically in the central part, suggesting that it has something to do with the environment or some aspiration. Pneumonia secondary to aspiration, there is a history of force feeding, and X-ray, there is a central consolidation. Against aspiration was some improvement but not complete recovery. And tuberculosis was unusual, if at all it was an unusual presentation. And so we thought that whether we are dealing with a hypersensitivity to dull aspiration. Next slide. You can see the CT scan which is showing in this one parahilar shadows, and there is in the upper image of the CT, you can see there is a paravertebral dependent part, lower lobe showing a significant consolidation and some nodularity, suggesting that it is probably a aspiration. Next. So other investigations were done. Blood culture was sterile, procalcitonin was normal, CRP was negative, bronchoscopy was normal, bronchial lavage for gene expert was negative, bronchial lavage culture sensitivity was sterile, barium swallow was normal, GER scan was normal, slight increase in IgE, sweat chloride was normal. So it is not giving us any clues. Next slide, regarding the underlying disease. And then because we considered it may be a dull hypersensitivity, so anti-lentil antibodies of IgG class was 117, which is very high, more than 10 may be considered as abnormal, and IgE was normal because it is a IgG mediated disease hypersensitivity. So based on these, we started the child on prednisolone 2 weeks full doses with tapering, and after 2 weeks there is a dramatic improvement from 60 plus to 38 per minute respiratory rate. Oxygen saturation is improved to 94 to 98 in room air. Air entry is equal, gaining weight, and you can see this was the first X-ray when the child came before starting prednisolone, and this is the second X-ray when there is a significant improvement. We stopped anti-TB drugs and we treated it as a possibly aspiration of dal, and which caused this lentil hypersensitivity pneumonitis. Next slide. So this is one of the diagnostic entity which has been documented by AIIMS team, and you should be considering this is not uncommon to find that the children are being fed, specifically infant, forcefully with dal, and they may continue to have this respiratory symptoms and bad X-ray, and we cannot blame the doctors who were treating with antimicrobial. But if you find such a case, think of alternative to TB or aspiration pneumonia or other thing. Thank you very much. Dr. Smriti, I think I have completed my presentation. If there are any questions in chat box.
Okay, thank you so much, sir, for your wonderful presentation. And you gave us very clear-cut, stepwise approach to the recurrent pneumonia, which is commonly seen in our routine practice. So if there are any questions, you can type in your chat box. We will, the faculty will give their answers at the end of the second presentation. So keep typing in the chat box. Thank you, sir. Now I request Professor Joseph Matthews, sir, to kindly start his presentation. Should I share your slides, sir, now?
Is this slide visible?
Yes, sir.
Okay, then shall I just go ahead?
Yes, sir. Yes, sir.
Okay, thank you very much, and apologies to everyone. The last time there was some glitch because of which WebEx was not connecting. So hopefully this will be all right. And thank you very much to Professor Kabra sir. As always, this has been an excellent class. I also learned a lot. This session of recent advances is not going to be as exciting and as practical because what I've done is I've looked at Medline to search for all articles which are systematic reviews in the last 1 year on dealing with any aspect of childhood pneumonia as a recent advance. So let me go through this very quickly. Now, the etiology of community-acquired pneumonia. Every UG and PG student knows the usual organisms that cause pneumonia. So is there a new kid on the block? Because a lot of papers are coming up which seems to suggest that it is not bacterial but rather viral, even in developing country settings. So this is one of the systematic reviews which came out in 2022 in the month of August, which looked at respiratory viruses. And they looked at 186 papers in more than 1.5 lakh children. And what they found is that one or more respiratory virus was present in 55% of the samples, nothing unexpected. RSV was the dominant one in about a quarter of them. And they didn't see a significant variation in terms of national income of the country, under 5 mortality rate, etc. Another systematic review has been published more recently in the Journal of Global Health, which looked at broadly the etiology in the so-called era of vaccination. So what they found is 55 studies of all different study designs. The summary result was basically this, that a limited number of pathogens was identified in children with pneumonia. But if you look at this, now the order is no more pneumococcus, H flu, and bacteria. Now it is RSV, HMPV, influenza, parainfluenza. So the first four dominant bugs are now viruses, and the bacteria have been put in the background. So from this, we might come to the erroneous conclusion that the world has suddenly woken up to the fact that RSV is the dominant cause of childhood pneumonia and the bacteria are less important. I don't think that is the truth because if you look at some of the studies which we have published from PGI, this was done in 2010 to 2014, even before we had pneumococcal vaccination in the country. It is the world's largest single center study on pneumonia etiology with about 4,000 children, of which two-thirds of the data has already been published. This included children from the ages of 1 to 12 years, but the majority were below 5 years of age. And we looked at all severities of pneumonia. What did we find? We found that if you take blood culture, which is the absolute specific sample for pneumonia etiology, then to our surprise, it is Staph aureus which was a dominant organism, not pneumococcus. Pneumococcus didn't even come a distinct second because even though it was present in about 80% of the nasopharyngeal aspirate samples, it was positive in only 15% of the positive blood cultures. Whereas if you looked at Klebsiella pneumoniae, this was hardly present in the nasopharyngeal aspirate samples, but 15% of the blood culture positive samples were also Klebsiella, suggesting that this has probably got a greater contribution to the etiology than pneumococcus. And if you look from this slide at all the gram-negative bacteria together, then they clearly outweigh pneumococcus. In fact, at that time in 2015, we had great difficulty publishing this data because nobody would believe in the international community that pneumococcus is not the dominant bug in India. We also did viral PCRs, as now everyone else is doing. And in about 40% of the samples, these PCRs could be done because of the cost factor. And RSV, as expected, was the dominant in over 50% of the cases. We took this study forward because we concluded from this particular thing that between bacteria and viruses, we can determine etiology in only about 1/3 or 30% of the cases, and the bacteria are lesser in number than viruses. So we knew this data in 2014 and we were able to publish it in 2015. That summary line at the bottom is what we concluded, and we made the bold prediction that pneumococcus is not an important bug in terms of the Indian context, even though it's probably important in other places. Now, later in 2015, looking at the fact that nasopharyngeal aspirates are not the right samples for determining pneumonia, we expanded this study to include other samples. So we did in 222 children a mixture of samples in which blood and nasopharyngeal was taken from everyone. Where we could, we took lung aspirates, bronchoalveolar lavage, pleural fluid, sputum and induced sputum, and also we did serologies for mycoplasma and chlamydophobia. What that data showed us was very interesting. We found that if we looked at organism-wise distribution in children with pneumonia, this is a rather busy slide, so don't worry about reading too much into it. Just look at the dominant colors. So in all these three bars, what you will find is yellow color is dominant and yellow color is RSV. The next dominant color appears to be this pink over here, and the pink is a combination of bacteria and virus. All these other bars below the yellow, right up till the pink, these are all actually viruses. So where are the bacteria in this? The bacteria are occupying a minuscule proportion in the first 3/4 parts. So if you look at the most conservative model, we find that bacterial etiology, which is confirmed either by blood culture or any other standard method like pleural fluid or lung aspirate or BAL, that is present in actually less than 10%. If you used a liberal model and you included some nasopharyngeal aspirates, then that number goes up to about 18%. In other words, here too what we found is that the viruses, as shown by the red color in these bars, outnumber the bacteria as shown in the green colors. And of course, as expected, a large proportion of children in this pale pink color are those in whom the etiology could not be determined because nothing showed up on the blood culture or the PCRs. So the new knowledge was, even if we looked at samples which are beyond the usual nasopharyngeal aspirate and blood culture, there too the viruses outnumber the bacteria and RSV is the dominant. Then, I must show you a little bit about this study, which is not published, therefore we cannot share the data completely openly. The ICMR led a 5-center study, which was designed as a case control study, much like the PERCH study which happened before this, to look at severe and very severe pneumonia in comparison to asymptomatic controls. So blood was done in all the cases, nasopharyngeal aspirates was done in cases and in controls, and PGMR contributed to a disproportionately large number of the children enrolled. So I'm showing you a little bit of the PGI data. So what happened is, in the blood culture, there was only limited positivity and pneumococcus was not there at all. When we looked at the PCRs, we found these kind of distributions between the strep pneumoniae, between the cases which are shown in red and the controls which are shown in green. So what you find is for most of the bacteria, the proportion of children with the positivity among the cases and the controls is pretty much similar. So the first 5 bars you see are the same. The big difference comes with this bar, which is RSV, far outnumbering the cases than in the controls. Little bit for influenza, parainfluenza, and HMPV, adenovirus almost common, and rhinovirus equal in both. When we look at the odds ratio, so the odds ratio of a child having pneumonia, if his RSV is picked up, was 7.3 as compared to if a control had picked up an RSV. Whereas for the other bacteria, it was pretty much similar. And this was largely driven by the fact that the bulk of the cases here were children under the age of 1 year. So this is data for those who are less than 6 months. You can see this big signal with RSV, not so much with the bacteria. This is between 6 months and 11 months. So again, you see the same signal with RSV, not at all with the remainder of bacteria. And then that signal starts coming down gradually as the infants grow older. So by between the age of 1 and 2 years, you can see that RSV is still dominant, influenza is still dominant, but other viruses are coming up. The bacteria still are evenly distributed between the cases and controls. And then, of course, in the largest group, which is children beyond the age of 2 years, right up to 5, then you only see a small signal with RSV, a little bit of signal with influenza. The rest seems to be evenly distributed. In other words, what we are seeing is we knew as far back as 2015-16 that viruses outnumber bacteria as etiology even in India, and RSV is the dominant. So what emphasis can we place on the fact that a lot of studies now are claiming that RSV is the important bug? I think these are somewhat commercially driven. So the pneumococcus literature was driven heavily by the fact that there was a vaccine available and it had to be used somehow. I'm afraid that the pattern is now repeating with RSV. Now the pneumococcal vaccine is pretty much used everywhere. A market has to be derived for the new upcoming, whenever it comes, RSV vaccine. And that probably is why we are seeing this re-emphasis or the renewal of interest in RSV, which otherwise we knew, at least for the last 8 to 10 years. So in summary, I think there's nothing that has changed in the etiology. No new knowledge as such has come out. It's just that we are repackaging the existing knowledge that we already have. Coming to the next, diagnosis. Now, in diagnosis, I'm not touching upon molecular diagnosis because the more refined methods of molecular diagnosis we use, the better will be our pickup of various bacteria and viruses. Nothing new has come out in the past year. I'm also not touching upon lung ultrasound, which has been hailed as an upcoming modality, but it's not proven in the field setting as compared to research. So touching upon, so what's coming up now is the dependence on technology. So there are tools now which have been devised called electronic stethoscopes. Even in the field setting where field workers are not trained to use stethoscopes and distinguish the auscultatory sounds, these digital devices, which basically consist of a diaphragm of a stethoscope with some electronics to amplify the sound which is picked up and read it either directly or through machine learning. These tools are coming up as a big way nowadays, and there is already a systematic review on this. So there are 10 studies which have looked at this, and most of them have concluded, just by way of apology, don't try to read this slide, it is very crowded. Most of them find that when you compare the sounds which are picked up by an electronic stethoscope in comparison to an existing database of respiratory sounds, they seem to perform very well. If you try to actually test them in the field, then they don't seem to have the similar specificity and sensitivity, although this varies depending on what kind of the population the study has looked. So I think this is a promising modality. A lot more work needs to be done before we can actually reach the level at which we can pass these instruments to field workers and say, besides counting respiratory rate, please also look at the auscultatory findings and either do it on site or beam it up through Bluetooth or something to a central repository, which will then be able to classify as normal or. The other area of interest which has come up is using technology for counting respiratory rate in an accurate and as well as manual free. So you all know that WHO's definitions for pneumonia hinge actually on this word called tachypnea. And tachypnea is so operator dependent that now people are using technology to see if they can accurately count respiratory breaths in infants and children. So this study has got published very recently in the archives. And what they basically have done is they've looked at an ordinary pulse oximeter whose tracing looks like the one in the last row, bottom row of this particular picture. Then they filter that and remove the heart rate component and end up with a waveform which is in the top row, and that is supposed to be looking like the respiratory wave. And when it is compared to the gold standard against bands placed over the chest or the abdomen, then you can see that the top row mimics pretty much the second and the third row, suggesting that an ordinary pulse oximeter, without using too much of hi-fi hardware, simply by modifying the software algorithms, might be able to give, in addition to pulse rate and oximetry, also the respiratory rate. If that comes through and it can be clinically validated, then we have a rich field because even in field settings, people can reliably measure this over a period of time, monitor trends even at home or through the hands of field workers. So this is another exciting development, but nowhere near the finish line yet. The third is some people are looking at automating the interpretation of chest radiographs so that they become consistent and use some artificial intelligence or deep machine learning to make this happen. So there is another systematic review which has found something like 7 pediatric studies and a mixture of studies with adults and pediatric. They looked at a lot of databases which have got child-specific X-rays in pneumonia majority and a few in other conditions as well. And they concluded that it is still in the early stages. We have not reached the level at which we can leave it to the machines. Seems to hold some promise, but we have a lot of work to be done before we get there. So I'm expecting that in the next 5 years, we'll see a lot of emphasis on digital stethoscopes, machine learning for reading chest x-rays, and also probably using pulse oximetry in a much bigger way. Then, this is a now new systematic review which has been looking at the prevalence of tuberculosis in children who present otherwise as a garden variety of community-acquired pneumonia with short histories. We know that if the history is beyond 2 weeks, then we do suspect pneumonia as a differential diagnosis. But when the history is shorter, then what is the pickup of TB in such children? And this literature is driven mostly by South Africa and a couple of other African countries, wherein there is so much TB prevalent that they often present as acute pneumonia. That sometimes happens in our setting, Our own PGI data showed that among all the children who turned out to be microbiologically confirmed with TB, 8% of the children actually had durations of symptoms shorter than 2 weeks, which is what is prescribed to start the search for Mycobacterium tuberculosis. So that happens. So this study looked at, this systematic review looked at a bunch of studies, and they basically found that the prevalence of TB in children who are otherwise present as community-acquired pneumonia varied from as low as 0.2% to as much as 15% with a median of 4. And as expected, TB was more likely to be picked up if there was a history of TB contact in the family, or if the child was HIV infected, severely malnourished, or even a younger child. And also, as expected, failure to respond to the pneumonia antibiotic therapy was another indicator which could predict TB. I think what it basically means is nothing enough for us to change our practice or start searching for TB in these children. Probably we just need to add in our armamentarium asking a history of TB contact, even if a child comes to us with what looks like a community acquired pneumonia. I think that is the only thing I would change. I don't think we should start investigating all of these children. But if there is a history of TB contact, as we would, whether or not a child presented with pneumonia, we would still search for TB in them. In those children, probably it might be sensible to take a look at if TB could be present using an X-ray and maybe some gastric aspirates or things like that. Then, so on the investigative or diagnosis front, this is about all that has happened in the past month. Coming to treatment, what could be the next blockbuster intervention? Do we have anything new on the horizon? Actually, we don't. We just have a rehash of what already existed, and here is some of the data. So looking at the short course versus long course of antibiotic therapy for children, this is a systematic review that I was privileged to work with a bunch of international people. Actually, this got published only 2 days back. What it looked at is the difference between the outcomes in children who got 5 days or lower versus 5 days and more than 5 days of therapy. So in terms of treatment failure, whichever of these two regimens was followed, which means studies which compared shorter than 5 days against 5 days, and studies which compared 5 days against longer than 5 days, the treatment failure rates were not different in whichever regimen was used. So if people are using 10 days regimen, which is what is recommended in the United States and other developed countries, they can switch to 5 days. If you're using 5 days, which is what we use in developing countries, we can switch to 3 days of therapy. And this result held good both for treatment failure and also for treatment relapse. On one side, it is actually intuitive because if you look at the way these studies have been done, especially in developing countries, many of these children who got treated with antibiotics probably never had pneumonia, which means if we were comparing them with no antibiotics, a majority of those children would also have remained all right. And that is the pitfall of using the WHO clinical definition with just tachypnea and fast breathing or uh, breathing difficulty with cough. So it picks up a lot of children with bronchiolitis and viral V's and things like that who really don't have pneumonia. So that is why we probably don't see a difference in treatment. But we need to turn this round a little bit and as clinicians wonder which is the cohort of children who actually need antibiotics for 3 to 5 days or longer so that they don't die in the community or worsen or come back with complications. I think the research in this year and the next will start focusing on that and we'll hopefully have some answers in a couple of years. Now, similarly, people have looked at sending children with chest indwelling pneumonia. Now, chest indwelling pneumonia is a surrogate for severe pneumonia. Earlier, the dictum was if it is non-severe pneumonia, you treat with amoxicillin.
ठीक है thank you.
Sorry, am I audible?
Yes, sir, you are audible. Kindly, other participants, kindly mute yourself.
Okay, thank you. So this thing, the dictum used to be that children with non-severe pneumonia treat with amoxicillin orally at home. Children with severe pneumonia, which is defined as indrawing pneumonia, and then earlier the very severe pneumonia term had indrawing plus danger signs. So the dictum was these should be treated in the hospital and given IV antibiotic. So people have looked again at this, whether the indrawing pneumonia group can also be treated at home. And this systematic review of 14 studies with 7 randomized controlled trials found that treating at home was either equivalent or in some cases superior to the treatment with hospitalization and IV antibiotic. And these studies were also able to confirm the feasibility. Two of these studies were from India. So which suggests again that even the so-called chest indrawing pneumonia might be possible to treat at home with oral antibiotics. And again, I think the principle is the same because there would be a lot of clinical conditions which have indrawing but are not pneumonia. And if these occupy both the groups which have received home therapy as well as received the hospital therapy, we expect to see no difference in them because probably they never required antibiotics. I think this data will get teased out in the coming year, and then we'll actually know which are the children or the sub-cohort of children who need hospitalization and treatment with IVIs. So it is hopefully an exciting time for the management in terms of this. Then again, nothing new here, but Professor Bhutta's team looks at vitamin A supplementation frequently because they have been able to consistently show that it somehow decreases mortality. We too had looked at this as far as back as 2010. We found no benefit of vitamin A. Then vitamin A fell into disrepute, and this group somehow brings it back into focus again through their systematic reviews and analysis of data. So the latest iteration of this systematic review was published in the Cochrane Library in March this year. No new studies were identified, so it's the same 47 studies with 1.2 million children scattered across 19 countries. This 1.2 is mostly contributed by the study with the million children, which came from India. And what they found is, as previously, all-cause mortality, diarrhea, and measles mortality showed significant declines if they were supplemented with vitamin A, whereas respiratory disease-associated mortality showed no difference whether they were or were not supplemented with vitamin A. The incidence of the disease, again, diarrhea and measles seem to be lower with children who were supplemented with vitamin A, whereas respiratory disease, which is a euphemism for pneumonia mostly, did not show any difference whether or not they were supplemented. So I think if you want to look at vitamin A supplementation, it may have a role in terms of diarrhea, especially, which also drives the all-cause mortality down. Doesn't seem to make any difference for respiratory. Those who read Indian pediatrics regularly might remember an article which was published in the Eureka section in 2010, which showed exactly the same thing for the pneumonia part. So nothing seems to have changed in all these years. Then, one systematic review has been done recently to look at whether the pneumonia caused by penicillin-resistant pneumococcus versus the penicillin-sensitive pneumococcus, whether these behave differently. And the reason for doing that is that authors used to suggest earlier that one of the reasons for pneumococcal vaccination is that the burden of penicillin-resistant pneumococcus is increasing. Those children do much worse than the others, so they might die if they are not treated, and so it makes sense to prevent. So this systematic review has been done very recently, published in, I think, August or September. And basically what it showed is 7 studies in nearly 3,000 children. They couldn't pool the data because the studies were of different designs and quality. But out of these 7, 1 high quality and 4 medium quality studies all showed that there is no difference in the clinical outcome by duration of symptoms or duration of hospital stay and even mortality when children had penicillin resistant versus penicillin susceptible strep pneumonia. 2 poor quality studies seem to suggest a better outcome with penicillin susceptible. So in other words, I think the world is now gradually moving away from this unbelievable pneumococcus, which probably had a different basis entirely, and now they're setting the ground for a new organism to become the center stage so that the treatment or the prevention of that particular thing becomes the important. Some emphasis is also being placed on pneumonia in older children. Up till now, we used to hear only of children below the age of 5 years. Now, in older children, people have looked at a systematic review to look at clinical features, just to see whether they're similar to what happens in the younger age group. And interestingly, this large systematic review, again, don't try to read this slide, just follow with what I'm trying to say. The usual symptoms which happen in younger children, which is cough, breathing difficulty, nasal flaring, grunting, and chest fall and drawing and all that, seems to be present only in a minority of children who have community-acquired pneumonia when they're beyond the age of 5 years. Even tachypnea was seen only between half to 3/4 of this. And as expected, hypoxemia in only 1/4 of it. So in other words, we can't assess pneumonia in older children using the criteria for younger children. which is what we also did in our large study by changing the tachypnea rate from 40 to 30. It doesn't seem to be true because a lot of children probably don't have these so-called hallmark findings. Same way for the examination findings, freckles only in half of them or less, wheezing in only a quarter of them, even fever is seen only in half to three quarters, and some other weird symptoms like headache and all that is much, much less frequent. The other symptom which they found to be very, very statistically significant was the presence of pallor, which seemed to have a bearing on the outcome. I think it just indicates a sicker child who might have pneumonia and anemia happening together. Chest pain, which used to be said in adolescence is an important symptom, was present in only one third. In other words, probably the emphasis of research will shift to these older age groups, and they may find a catchment in this age group to vaccinate with whatever vaccines are available, given the fact that the younger population is already in the vaccination net. To conclude, what is the take home message from all that I'm trying to say in the recent advances? I think the main thing is there is really no significant advance which has happened in the past 1 year with regard to childhood community acquired pneumonia. There is a spotlight which has been placed on RSV. It is not a recent advance. It has been known for the last 5 to 10 years at least in different settings. It is just that the spotlight has been placed, setting the ground right for whenever the RSV vaccine or prevention is available, there is a ready market to take up for that amongst not just the commercial market, but also policymakers, physicians like us, and the scientific community in general. I think that ties in with the lower emphasis which is being placed on strep pneumonia, which is what is now to be gradually taken as routine, just like hip vaccine is now counted as routine. Pneumococcal conjugate vaccine will become routine. So probably they will identify other age groups and other priority conditions for that vaccine and move the spotlight to RSV. Coming to pneumonia diagnosis, the conclusion is evident. It is moving towards technology. We are nowhere close to using technology to become the diagnostic modality for pneumonia. Till then, we'll still continue using clinical judgment, X-ray findings, and things like that. Ultrasound is showing some promise, but there is too much data to show that ultrasound done in the hands of inexperienced people who are not trained to do ultrasound properly ends up having too many errors. In pneumonia treatment, nothing new except this phrase, less seems to be more. So it's moving towards shorter durations, no need to hospitalize. Some forms of severe pneumonia can be treated at home, and probably there is also an emphasis now which is going to go away when the WHO comes out with revised criteria for pneumonia diagnosis. We'll probably see a little bit less use of antibiotics, given the fact that it fosters antimicrobial resistance and there is emphasis on antibiotic stewardship. Till that comes up, of course, we are treating empirically the usual way for all these things. Nothing new in the terms of pneumonia outcome, but I think the carry home message that I would think is the recent advance would be that physicians and scientists are having a difference in thinking now. Hopefully, in the next 5 years, we will see that in the epidemiological triad of agent, host, and environment, wherein the agent is the microbe, we'll see lower emphasis on the agent, we'll see greater emphasis on the host, to look at the host mediated responses, whether it is inflammatory or immune mediated, because that is what probably causes difference in clinical course, outcome, and even mortality between children who have the same infection with the same bug but seem to behave entirely different. And we already know that with the environment, what it is currently, and the levels of particulate material which is circulating, and how these inactivate secondarily the ciliary movement and create a problem in which the body's defenses are compromised. I think we'll see a lot more literature coming up in this area in the next 3 to 5 years. So on that note, that is all I have to suggest in terms of recent advances. Thank you very much, and we can take questions.
Thank you, sir, for very well summarizing the recent advances. Though they are not much advances in terms of etiology, but there have been significant advances in terms of diagnosis, particularly the molecular diagnosis, as well as technology-based diagnosis, as well as in treatment, which is going more towards conservative. So I thank both these speakers uh, for sharing their wonderful knowledge and enlightening us with their experience as well as knowledge to us. So I request Dr. Nalini, she is Assistant Professor in the Department of Neonatology here, to moderate the question and answer session.
Thank you so much, ma'am. Thank you so much, sirs, Dr. S.K. Gabra and Dr. Joseph L. Matthew, for the crystal clear presentation. And I would like to ask audiences here, do you have any questions to ask the speakers? Very clear? Okay. So now I take on questions from the chat box and question answer session. So, sir, any updates on cost-effective diagnostic for viral pneumonia? Maybe Dr. S.K. Kabra sir can answer this, or Dr. Joseph sir.
Yes, certainly. I typed back in the chat box actually the answer to that question. So the cost of PCR is coming down. Even next generation sequencing costs are going to come down. So the temptation will be to send inappropriate respiratory samples, which is nasopharyngeal swab, because that is easy to get, and start doing PCR in all of these to look for these bugs. I sincerely advise to desist. If you're doing PCRs, molecular diagnostics, then it should be done from an appropriate specimen, and nasopharyngeal is not the appropriate specimen. You have to either get sputum, which is a surrogate for lower airway specimen, or lung aspirate, or bronchoalveolar lavage. So literature will get flooded in the next 2-3 years with a lot of studies which have looked at beyond PCR, even NGS, but no need to get confused by that. And as the costs come down, people will start using it more.
Thank you, sir. And any updates on RSV pneumonia regarding treatment options and the role of ribavirin in children?
So nothing new. RSV was a bug which was very important. We knew this about 7 to 10 years back. It's coming into focus. As and when the vaccine comes, then India scientists will have to grapple with which should be the appropriate age group and who should be the actual people to get this vaccine. Ribavirin standard recommendations, nothing has changed. No change in the treatment update on RSV. They have to be monitored and watched because sometimes RSV does cause systemic involvement as well.
Thank you, sir. And sir, can you please explain pulse oximeter waves and pneumonia?
Right. So pulse oximeter doesn't do anything for pneumonia. So pulse oximeter is being used to filter the plethysmograph signal which comes, remove the pulse waveform which is the heart rate component, and look at the respiratory rate component in that. So earlier it was not possible because that filter was very difficult to achieve mathematically. So it's not a device. The filter is not a device. It is a mathematical algorithm. Now that has been achieved by 7 or 8 groups across the world. So they're able to get a respiratory rate reading from a standard pulse oximeter, which is used in field settings, even at home. So when that happens, the respiratory rate counting, which WHO has trained peripheral health workers to do using timers, that will become digitized and automated, and so hopefully we'll get much more reliable rates. And for children who are being monitored inside hospitals, we'll be able to get a continuous waveform rather than the manual intermittent rate that we count by looking at the child's test for 1 minute and things like that. So that is the only development on that.
Thank you so much, sir. Since there are no more questions, I hand over to Dr. Samriddhi.
Thank you, sir, for clarifying the doubts of the audience. And since there are no more questions, so we will be concluding this CME by giving the vote of thanks on the behalf of Pediatrics Department. We thank our esteemed faculty for sparing their valuable time from their busy schedule and enlightening us with their knowledge and experience. And I thankful our wonderful audience for joining the event and hope they must have enjoyed and they have a great learning experience. And lastly, I thank my colleagues for their continuous support to make this event memorable. So because there are many residents in the CME, so we have an online quiz for them. So I'll be sharing a link with them on their email IDs, and it will be active for 30 minutes. So kindly participate in that quiz. And with this, I thank everyone. Thank you, sir. Thank you, everyone. Can you all please on their videos just to take a photograph together? I request everyone to kindly please switch on their videos. Thank you everyone for joining this CME and making this a wonderful event. And you can now leave the CME if you want.
Shall we leave then? Thank you.
Yes, sir. You can leave, sir. Thank you so much, sir. Thank you.